Hi everybody, this is Dr. Jenny Peters and I'm going to be talking to you about rheumatology. These will be in different sections, so I will be posting, there will be a few separate videos. I'm going to be talking about rheumatoid arthritis as compared to osteoarthritis. And then lupus, fibromyalgia, polymyalgia rheumatica, giant cell arteritis, or otherwise known as temporal arteritis and gout. When to refer and the guidelines for treatment. I'm not going to go into pathophysiology as you've had pathophysiology, but I really want to go over the basics and then how to diagnose and treat and when to refer. Because when we see patients with these issues, how do we know when to refer? How do we know what kind of workup to get in primary care? So this first one is going over the difference between inflammatory versus non-inflammatory issues. So osteoarthritis, for example, as compared to rheumatoid arthritis. So one of the main differences is osteoarthritis is usually one joint and not symmetrical. Although people can have bilateral knee osteoarthritis, bilateral shoulder osteoarthritis, but rheumatoid arthritis is known, it has to be symmetrical because remember it's an autoimmune issue. So you have other things going on with your inflammatory markers and interleukins, and if you go back to the immune system. So that's symmetrical. Osteoarthritis is not necessarily symmetrical. The other thing is morning stiffness. So with osteoarthritis, you get out of bed, you start moving around, you get in the shower, and things start loosening up. You feel better, right? But with rheumatoid arthritis, you get up in pain and you stay in pain throughout the entire day. Because remember, again, it's not a mechanical issue. It's more of an immune system issue, inflammatory issue. All right, so we're going to move on. Now I'm going to start out with osteoarthritis, just an example of what that is. So if you see cartilage here, this is pretty still healthy cartilage, because remember it works as like a padding between the joints. And as we move on to the different stages, that padding or that cartilage is completely worn. So you can imagine how painful that can be for someone. Hip replacements, knee replacements, when they start having moderate to severe, what we call degeneration, and you'll see that on x-rays, that's when these people really need consults with orthopedics to see if that would be an option or on the table for replacement. Osteoarthritis is very common, if not the most common disability. Right now it's the second leading. And when I did this slide, I kept this slide up because I did this probably like 5 years ago. It estimated that 59.4 million will have OA by the year 2020. It's not there yet. It's about 35 million patients. So here's the distribution of it. You can see that people have more osteoarthritis in the hips and knees. You'll hear a lot about knee replacements, hip replacements, but also look at the hands. And as compared to rheumatoid arthritis will have it more in Okay, so with rheumatoid arthritis, you'll have the wrists and these joints, whereas osteoarthritis, you will have it more in the dip and pip joint, it's called, the distal and the proximal joints. Here's some examples, and what these are called are Heberden's and Bouchard's nodes. So Bouchard's nodes are the proximal, so they're the pips. Those are Bouchard's nodes. You see how they're swollen there. And then the Heberden's nodes are the distal, the dips. So the dips and the pips. So make sure you know the difference between Heberden's and Bouchard's and where they are at. And these are related to osteoarthritis only. How do you diagnose it? Well, usually it's just by a history and it's supported by x-ray. So if somebody comes in and you take a really good history, because remember, you can tell what their diagnosis is about 80% by doing your history. About 80% of the time you'll know before you even do an exam. So an elderly patient or even middle-aged patient comes in and they have bilateral knee pain or just single knee pain, or they have wrist pain. You can get an x-ray and it'll show degeneration. Now, when I say bilateral, yes, rheumatoid arthritis will be bilateral. Osteoarthritis can be also, but when you get the x-ray, it's going to appear different. You're going to have more inflammatory issues going on the x-ray versus degeneration of the joint. How are we going to treat it? Well, NSAIDs, analgesics, COX-2 inhibitors. You can tell them to go get some glucosamine, chondroitin. So as far as analgesics and NSAIDs, now Tylenol is what's recommended. And NSAIDs people like to take because many people say that the NSAIDs just work better. But we really have to be careful of side effects, GI side effects, cardiac side effects. Going back to pharmacology, your COX-2 inhibitor, your Celebrex is another option. They don't have the GI side effects as much, but it does increase the risk for cardiac events. So it's one of those weighing the risk versus the benefits. I have seen several times working in primary care. Patients come in, they have a GI bleed from taking naproxen every day for months. So Tylenol is the recommended treatment, and then NSAIDs I would say for breakthrough pain and only do that for a couple weeks at the most. The glucosamine they can take every day. There is evidence out there that the glucosamine chondroitin is helpful for joint movement. Also, let's not forget about the non-pharmacologic approaches. And other treatments, which I had mentioned before, is joint replacement surgery. All right, so before we go to inflammatory arthritis, I want to make sure that you understand the terminology, because if you know the terminology, it's real easy to look at a term and say, oh, this is what this is. So mono and polyarthralgias. They have many joints that are in pain. Monoarthralgia. They have one, my wrist hurts. Spondyle means spine, so spondylolisthesis. Spondylarthropathy, so it's your vertebra. Artero is arteries, you know, like atherosclerosis, itis, inflammation, osis, abnormal condition of, scleros, think of scleroderma, hardening of the skin, that's a connective tissue issue. Myo is muscle, algia is pain, ankylose, when you think of ankylosing spondylitis, stiffening of joints, these all go together with rheumatologic disorders. So I highlighted the ones that I'm going to be going through, but these are some of the inflammatory disorders, and a lot of these are related. So if you have one, you are more likely to have another one. So if you have lupus, you're more likely to have Sjogren's. So rheumatoid arthritis, and this is a very advanced form of rheumatoid arthritis, late stage, and as you can see, they have deviations in the joints. They have deformity of the thumb. And this deformity here is called the swan neck deformity of the fingers. So the difference now, symmetric, inflammatory, it'll be swollen, red, warm. Polyarthritis, it's not as common as osteoarthritis, but it's an autoimmune disorder. More likely a female will get it, and genetic, autoimmune, and environmental. So autoimmune diseases are still a bit of a mystery to all of us, and but we do know, yes, autoimmune, we know that there's cytokine involvement, the interleukin involvement, complements, remember all that immune system stuff, the tumor necrosis factor, that's all involved. And so whether you developed a virus or a multitude of things or environment and that caused an autoimmune response, the jury is still out on that. Now here's the rheumatoid arthritis distribution. As you can see here, remember the osteoarthritis, you had the dip and the pip. Well, now you have more of the wrist joints and these more proximal joints. So the only one that would be the same would be the pip joint here in the middle. And hips aren't involved necessarily. They do have knees. So you see there's some overlapping between the rheumatoid and the osteo, but the main things is that rheumatoid is symmetrical. The pain does not go away during the day, and it's an inflammatory issue. This is just an algorithm I kept on here. I know it is blurry. I have other slides, though, that will explain it more clear, but I just wanted you to be able to see an algorithm. And you can find algorithms on UpToDate. If you have access to that when you get out and work, most people have access to it. But it basically will tell you if you have tender points, you might want to think more fibromyalgia. Fibromyalgia is more on a muscle than a joint. If you've had symptoms greater than 6 weeks, that's when you consider things chronic. So that would be with anything. Have you had it more than 6 weeks? That 6 weeks mark becomes more of a chronic issue, and you really need to look into things. And then it goes into the labs, which I will be talking about. I just wanted to show you again the difference. What you see is different here. Rheumatoid is more symmetrical, as osteo might not necessarily be symmetrical, and the spine is involved in that also. Fibromyalgia, they're tender points on more of the muscle connective tissue area, and gout is the joints, more so on the lower extremities. I linked an article here that's fantastic. I recommend reading the entire article, but a lot of these slides will be going through many of the components. When you're doing an exam, you want to make sure you're checking all joints. So you're just going head to toe. You're checking for effusion. Is there fluid, swelling, pain? Is there some deformities? And neuropathy, because what happens is there's joint destruction. Synovitis is the name for inflammation of that joint, and that can press on nerves and therefore cause neuropathy. So you want to check all joints for that. So how do we diagnose rheumatoid arthritis? There's a classification system that is based on 4 factors: the joint involvement, serology test results. There's other what's called acute phase reactant test results. That means a SED rate or a CRP, and what the patient's self-reports. So you add those points up, and this is in that article. The maximum number of points possible is 10. So a definite RA requires 6 to 10 or higher. If they're lower, then you reassess them over time and you use this classification. So number 1 is joint involvement. So you do your exam, thorough exam, and if they have swelling or tenderness on exam, then that will count. So as you can see, if you have 1 large joint, then that's 0 points. If you have 2 to 10 large joints, that's a point. 1 to 3 small joints, each one gets a point, or you give it 1 point. And as you can see, more than 10 points would be at least 1 small joint plus any combination of large and additional small joints. All right, number 2, serology. So when you see these patients and you are suspecting there could be something going on, you bring out your handy-dandy classification here, and it's okay to bring it up during an office visit. I tell patients all the time, I want to look up the guidelines, and because it's always changing, and there's a calculator that we need to go through to see what is the next step. So the serology, there's no reason why in primary care you can't get your usual CBC, CMP, a rheumatoid factor, and an anti-citrullonated protein, and an anti-CCP. So you can go ahead and order those. Rheumatologists appreciate that because that helps provide a basis, or it will help exclude a diagnosis or possible diagnosis of rheumatoid arthritis. And then you are given points. This is your SED rate and CRP. They will be given a point if it is elevated. And then the symptoms. So if it's shorter than 6 weeks, 0, 6 weeks or longer, 1 point. So that is how you will calculate that up to determine whether a further workup is needed or do they need referral. What if you get all of these? And actually, if I had a patient with less than 6 weeks of symptoms, I would not even do any of those labs. I would wait until it's 6 weeks or longer. If they have tenderness to some of the joints and the picture seems to fit, then that's when I would start calculating this up and ordering labs to get more of a definitive diagnosis whether it would be or it would not be rheumatoid arthritis. You don't want to always jump to getting an anti-CCP antibody, but if you are suspecting and it's greater than 6 weeks and you're getting your family history, because remember, all autoimmune diseases at some, not all, I should say there's a grouping of some that are genetic that go down the same genetic alleles. Because we want to catch this really early and we want to get treated early. Studies show if we treat within 6 months, it can reverse damage and halt progression or delay the disease progression. How do we treat? Usually we treat with methotrexate is the most common, but it is recommended too that we put it with the Biologic DMARD, which I'm going to talk about. They also, you see many of them on anti-inflammatories. Again, watch for stomach ulcers with that, but many of them are on them in between. So whether they're on even prednisone or in between. You have some patients that are on chronic prednisone treatment. That's, you know, we don't like to do that, but sometimes they are. NSAIDs, over the counter, your Advil, Motrin, Aleve, or there's your stronger NSAIDs like the Celebrex, COX-2 inhibitor, indomethacin, although that's not really recommended now. Just remember your side effects whenever you're prescribing. Your steroids, same thing. It can slow joint damage, but remember with steroids you can have a whole slew of other issues. These are when you have flare-ups. So with rheumatoid arthritis, you're constantly watching a SED rate and CRP. Once those are elevated, oh, there's a flare-up going on, they may give you a short corticosteroid dose burst to help with that. And patients love steroids because if you have that much pain and you're on a steroid, it really helps. The next thing, I want to talk about non-biologic DMARDs and biologic. You're going to hear DMARDs a lot. They stand for disease-modifying anti-rheumatic drugs. So there's non-biologic and there's biologic. The non-biologic are your, let's say the older ones like methotrexate, hydroxychloroquine, sulfasalazine. Those are usually given first. These can help slow the progression, but they're often used in conjunction with the biologic DMARD. So remember that. So I put it in red. Side effects can vary, but you're always going to monitor your liver, your kidneys, a CBC, and severe lung infections. So we'll go to the biologics in a minute, but that's when you have to get TB testing prior to starting that, because we want to make sure it changes your immune system around. The only thing with Plaquenil, they should have eye exams periodically and before, because it can cause retinopathy. We see most people start on methotrexate. Also, another really rare reaction would be a Stevens-Johnson syndrome or Dress syndrome. So if you want to look that up, if you can't remember what that is, my sister-in-law ended up getting that from sulfasalazine. She's still paying the price for that. She was only on it for a couple of weeks. She was sick in a burn unit for a long time. Now we have biologic DMARD agents. These are the ones that target your immune system, that trigger the inflammation, that causes joint tissue damage. But remember, these also alter your immune system, so you can get infections. So you should get TB testing prior to treatment. And as I stated in the last slide, these are most effective when paired with the non-biologic. And you probably have heard of some of these. I did go ahead and write, because there's different types of targeting the immune system areas. So, for example, Humira and these target your tumor necrosis factor. And this is the JAK, which we will talk about in a couple slides here. But all of these are biologic DMARDs that affect the immune system. The anti-TNF, so the tumor necrosis factor inhibitors, they target the tumor necrosis factor. And what these do, these inhibitors are actually made from a lab, and when they put, when you're getting an infusion, it causes a reaction that blocks the immune system. So your immune system normally makes tumor necrosis factor, but your body helps keep those levels steady. But if you have an autoimmune disease, then you start making too much tumor necrosis factor that leads to inflammation. So by giving these drugs like Humira, it will hopefully help block that system and reduce inflammation. The JAK, Janus kinase inhibitors, that is we have a pathway, which if you want to look that up, go ahead, but it's a signaling pathway inside your cells that has to do with inflammation, hence rheumatoid arthritis. They're enzymes, they transmit signals that are from the cytokines and growth factors. And so these help to inhibit that area of inflammation. So as you can see, a common theme that these biologic DMARDs are targeting a specific part of your immune system that causes inflammation. And when you have an autoimmune disease, remember your body's kind of attacking itself, and those specific areas are not functioning. It's important to know some long-term complications of rheumatoid arthritis, because when you see these patients in the office in primary care, they should be following up with a rheumatologist, but you as primary care need to be watching out for these complications also. You have to look at the medications they're on. Is their immune system could be affected? Or just long-term in general, such as the joint deformity, what non-medication modalities can be done. Anemia because of the medication they're getting, infections, GI, osteoporosis. It's more common, especially in postmenopausal women. Lung disease, fibrosis, and this has to do with the disease state in general, but if you smoke, you have a higher risk of it. Heart disease. Remember, rheumatoid arthritis is a systemic disease and not just a joint issue, mechanical issue like osteoarthritis. So it can affect blood vessels, increase the risk of heart attack. Sjogren's is common, dry eyes, dry salivary glands. Felty syndrome, which is basically a triad of a large spleen, you have a low or a high, actually it's a low white blood cell count, and you keep getting infections. And it can respond to the DMARD drugs. And then also lymphoma and other cancers. So these people should be seeing rheumatology, but in primary care, if you are suspecting rheumatoid arthritis greater than 6 weeks, if they have multiple joints, and especially the hands. A lot of times the hands are the first thing that you notice with rheumatoid arthritis. And if you get a simple bilateral hand x-ray, that can show if there's some joint destruction or anything that would suspect. So hand x-rays are important, or x-rays of a joint, a specific joint, if things have been going on greater than 6 weeks. Because the x-ray results are going to show different between osteoarthritis and rheumatoid. That would prompt me to go ahead and get a further workup with the rheumatoid factor, with the with your citrullonated peptide antibodies. There's both of those tests, your SED rate, CRP, and your CBC and CMP, or you can get a liver panel. Also a bone density. It takes a long time to get into rheumatology in most communities. If you're lucky, you'll get in within a month. So this is why rheumatologists appreciate us in primary care being able to do an initial workup on these patients. And if they are coming back positive, that's when you call the rheumatologist personally and say, hey, I have this patient, and this is what's going on. They have a positive this, positive that, and they will probably fit them in sooner. just to go back though, there's many people that are rheumatoid factor negative, and the sensitivity and specificity is not as good, or sensitivity I should say, is not as good for the rheumatoid factor. So you have to look at the whole picture. And if you're not sure, you call a rheumatologist and you talk to them.